Yes, you can start. Thank you.
Good evening, everyone. My name is Yashodhan Brahme. I'm a resident from SAN Pediatrics. I'll be presenting the long case for today's Thursday clinic. My child is a 1 year, 3 month old female child. She's second by birth order. She's born of non-consanguineous marriage. She's a resident of Powai, hailing from Gulbarga. She's Buddhist by religion, and she's brought by, and the informant is Vada, with complaints of vomiting since 1 day and fast breathing since 1 day. On inquiry, actually, the child has significant recent past history as well as a recent history of hospitalization. So I would like to start with the past history of this child. On inquiry, the mother has given a history of inability to gain weight since last 6 months, which has been noted by the mother. The child was asymptomatic otherwise till 10 days prior to the current admission. This is a second admission in the last 10 days. At this time, this child was at her native place in Gulbarga, following which she had developed vomiting, which lasted for around 7 days. There were 3 to 4 episodes every day, a small to moderate quantity, with around a cup full amount. It was yellowish, containing undigested food particles. The vomitus was non-bilious, non-projectile, and non-bloodstained, and it worsened till the day of admission on day of illness 7, and it resolved on the after 1 or 2 days of admission on treatment. So this was also followed by loose stools, which have been there for 5 days. The loose stools on day 3 of illness, and initially 4 to 5 episodes of small quantity, yellowish, non-foul smelling, semi-solid loose stools. There was no evidence of any blood, mucus, or worms in the stools. These loose stools gradually reduced in frequency and improved in consistency by day of illness 7, and they were not associated with any abdominal pain. After this, the child has also developed fast breathing that was noticed on the day of admission, that is the day of illness 7, and then the child was admitted to the to a outside hospital. There was history of lethargy in form of reduced overall activity and reduced verbal responsiveness on day of illness 7 that was reported by the mother on probing. So throughout this development of symptoms on day of illness 6, this child was brought to Mumbai by her parents for further management. They had taken some local medications for the vomiting and loose stools. On day of illness 7, around 4 days prior to the current admission in Sion, this child was admitted in an outside private hospital, where she was admitted in the ICU. She required non-invasive oxygen support and some IV medications along with fluids.
मैम
This
एक
child
साइड से
then
25 जुलाई को ये डोनेशन किया था, डू यू कंफर्म? इतनी सारी डोनेशंस होती हैं, सारी तो याद नहीं रह सकती ना। श्योर श्योर आप
so
अपना
the child has
क्या आपका सिग्नेचर है?
uh, Pallavi ma'am, can you please mute everyone? Thank you. This child, then on admission, showed symptomatic improvement along with complete resolution of symptoms within 2 days of admission and was later shifted to their ward. This child was completely asymptomatic for 1 day, after which she was discharged, and she was all right for the next day as well as per parents. 1 day after the discharge, the child has developed the aforementioned chief complaints since morning, where she had vomiting, which was acute in onset. There were 2 to 3 episodes of vomiting, small to moderate quantity, around a cupful, yellowish, again non-bilious, non-bloodstained, and non-projectile since morning. And that was also followed by an increased rate of breathing, just the mother in the afternoon. This child was taken to a local practitioner and then was referred to Sion for further management. Moving on to the negative history, there's no history of fever to rule out any infective etiology or underlying sepsis. There is no history of any consumption or any alternative drug therapy. There is no history of polyuria or oliguria to rule out underlying renal etiologies. There is no history of severe abdominal pain, polyphagia, hyperpigmentation, or salt craving behavior to rule out endocrinal abnormalities. There is no history of abnormal odor to body fluids, any developmental delay, or any similar complaints in the family, or any worsening of symptomatology after introduction of new food groups to rule inborn errors of metabolism, such as storage disorders. ANC history wise, it was an uneventful ANC where the mother was registered, taken supplements, had adequate weight gain during pregnancy, and there was no history of any medical illness. This was a full term birth, spontaneous vaginal delivery. The child cried immediately after birth, and sorry for the typo, the birth weight is 3 kilos. And there is no history of any NICU stay. There is no history suggestive of any neonatal seizures or encephalopathy. The child was active. She was discharged on day of life 2 after vaccination on exclusive breastfeeds. Developmentally, the child started cruising at around 10 months of age. Now she's 1 year, 3 months old. She started walking with support at around 11 months of age. Now she is able to walk a few steps without support. She has developed mature pincer grasp. She speaks in bisyllables. She can say mama, dada, and papa. And she has social stranger anxiety and waves bye bye. Impression is appropriate for age. Dietary history, the child is still takes predominantly milk-based diet, still predominantly breastfed around 10 to 12 times per day, with poor complementary feeding in form of dal rice and uh, dal ka pani and chawal ka pani is what the mother describes. There is a calorie deficit of 450 kilocalories per day in this child and a protein deficit of 4 grams per day. Family history, there is no complaints of similar complaint. There's no history of similar complaints in the family. There is no history of any sudden unexplained deaths in the family. So
Okay, so now just put things in context. We have a 1 year, 3 month old, right? 1 year, 3 month old child whose mother noticed that he is not putting on weight till over the last 6 months. And 10 days back, this child started vomiting, right? That's the story. So now you have described the vomiting. Now, what are your thoughts on this vomiting? So let's do an exercise of trying to decide that what is the origin or what is the anatomy of this vomiting, right? What do you think?
That it is non-projectile, so probably not coming from CNS, non-bilious, so non-obstructive causes are out. And there is
So one sec. So let's develop an approach. Suppose somebody comes with vomiting. Common sense should be the first anatomy that should come to your mind.
gastrointestinal.
Local, right? Now you have to think that does it fit to local, and therefore it's not local, then what else can it be? And it can be many things, like you said, CNS, etc. So take the question, do you think this is local?
Child also had loose stools at that time. So maybe without fever, loose stools and vomiting can be a cause.
So now go back to whatever children with a gastrointestinal cause of vomiting. How long does their vomiting last?
2 days, 2 days average, not more than like not 7, 8, 10 days.
And how is that vomiting? What is the timeline between that thing and the loose motions? What is the intensity? Any thoughts on that?
Sir, vomiting of vomiting of gastrointestinal origin will be it will be small to moderate volume, and it will be non-projectile, and it will be non-bilious if there is no obstruction. And, and,
Spasmodic pain is usually accompanied if child also has loose stools and vomiting, which is not there in this case.
Yeah, I think you are right that first we start with an upper GI. This is obviously upper GI. Okay. Now, read carefully what it is. It's a large amount. Okay, cup full. Now, generally, vomit at that age, this child is just an year and 3 months. Why is he throwing a large amount? Now, let's believe that this history is exactly what it is. So that bothers me a little. So large amount means, is there some obstruction, retention, whatever? The next thing is undigested food. That means there is not enough time for food to be digested in the stomach. Okay, obviously there is no bile, so we don't go down to decide what the vomiting is. So even when he came on the first day of this vomiting, two things should have alerted you and said, oh, large amount and undigested food. That means possibly not reaching the stomach, or it's reaching the stomach for a very short time and coming out. That's the first thing. So you start wondering whether it's an esophageal anatomy. Okay. And in a small infant of that kind. Now there is no other symptom at all. Knowing this on day one of this child's vomiting, we could have anticipated this is not a simple gastroenteritis. This is something going different way. Means the idea of such discussion in such this clinic is to sensitize us right from day one. And we could have been warned that there's something amiss. What could be the amiss in esophageal disease? Give a thought. I'm trying to say it's an esophageal. I may be totally wrong as the whole story comes up. It may be totally different, yeah. But we start thinking right from the first sentence that the parents tell us.
So what we want you to pick up are the deviations from the classic pattern, which should alert you, as sir said. So tell us typical gastroenteritis. What is the history you get? Think and tell us. The usual rotaviral gastroenteritis which children come with. What is the history you get?
So, there is a prodrome of fever, in some cases, followed by large quantity loose stools, which are usually watery, but they take 3 to 4 days, and it usually subsides on its own. The vomiting, however, is maybe 2 to 3 episodes, small quantity. It may be initially in the first 2 to 3 days of illness, and then it resolves on its own.
What is important is it starts with vomiting. The vomiting quickly resolves and is followed by the loose motions, which are large, watery, etc. So these are the things which are not there in this case is what we want you to pick.
And I think at this point, I'm talking about day one. Okay, I've made out that there's something amiss. My next question should have been, is the baby ready to feed? Okay, or there is a refusal of feed. What is the difference between two? One baby comes with refusal to feed and the same story. And the other one, no, wants to feed, but throws up. Give a thought. So one, yeah.
Esophageal cause will have a difficulty in swallowing. So they may present with an outright refusal to feed. Children in severe dehydration, or somebody who has lost a lot of fluids and has gone into a severe dehydration, will have refusal to feed or drink, whereas somebody in some dehydration will be eager to drink. Somebody with an obstructive cause, somebody with a painful lesion will be refusing to feed, but that will not be the case.
You're right. So what I'm trying to say simply is that if there is a refusal of feed, it's a systemic disorder, like wherever the system is. And if it's a ready to feed, then is it an obstructive disease? Wherever the obstruction is it achalasia? Is it some obstruction from outside? Whatever. That's the next step. So that would have started telling us that no, this is possibly a systemic disorder coming. Okay. And not the local. Okay. Local at that age would have also had possibly forcibly coming out of such a large vomit, your next question would have been, has he developed cough? A small infant throwing up a cup full, how will he throw it out? He will definitely partly aspirate. And the mother says, no, it's not cough. Then her cup is small. Okay. It's not cup full. So I think this is the way you start thinking. Okay. And then we feel it could be a systemic disorder. Okay. Now we start looking at, tell me which all organs can cause vomiting as the only symptom for a week.
Outside the GI tract. Remember, the loose motions here started 5 days later,
Yeah. So
on 5th day. So first 5 days, only vomiting 4-5 times a day. So with this in mind, think of what all organs can it be.
But CNS can cause vomiting. Even nephro causes.
Okay,
when-
one. CNS, very good. Now rule out CNS.
So there is no irritability, no seizures, no behavioral changes. Long-term CNS issues are also not there. The child has milestones which are okay. No headaches, no symptoms related to CNS. No symptoms.
Second,
So kidney causes.
very good.
So there might be metabolic derangements, which eventually leads for compensatory increase in respiratory rate and the vomiting. Mm, liver can also cause to vomiting if the serum bilirubin is high. Liver dysfunction can cause vomiting.
So again, you're right. So now again, think of the pattern and see whether the pattern fits in here. So suppose you see a acute infectious hepatitis. What is the pattern?
Initially, there will be a viral prodrome, which is a fever, vomiting, anorexia, mainly refusal to feed, and all this. And followed by this, there will be an icteric phase. But icterus, after prodrome, mainly 1 to 2 weeks will be the initial prodrome period, which is not fixed. And
Around 5 to 6 days, the icterus should start coming.
and so the other thing is, so this is not CNS at this point of time. Okay. If it is a kidney doing it, then is it an acute renal disease or a chronic renal disease?
So probably a chronic one because mother has noticed 6 months of no weight gain.
And now that says this child has not been gaining weight for a long and asymptomatic failure to gain weight. Of course, it could be simply no proper complementary feed itself. We should not forget that. But a chronic renal disease. And then there is no semblance of anything else in chronic renal disease. There is no glomerular disease, edema, etc., no tubular polyuria, etc. Okay. So possibly not chronic renal, right? Could it be liver, acute or chronic? Vomiting.
What do you
Acute or
think?
chronic?
Liver acute liver disease or chronic liver disease? Acute. Yeah.
Acute, right? And there's no reason for loss of weight, but loss of weight could be whatever it is. And when it is acute, as vomiting, then there is almost a beginning of an encephalopathy and race syndrome. That would have gone fast. So this is not liver. This is not kidney, possibly. Okay. And this is not CNS just now. Then what else? He's not coughing. At the end of cough, you may vomit, but that's not so. Okay. Then what other organs could give you vomiting?
Endocrinal derangements.
Right.
Endocrine,
Endocrine. And by that you mean adrenal mainly.
adrenals or
Okay. So adrenal. Now, adrenal losing weight for a long time. Okay. It's not acute adrenal. No, acute adrenal, does it present with vomiting?
Acute adrenal crisis can present with fatigue and vomiting.
So acute adrenal may have a vomiting to begin with, one or two, but will come with even failure, shock. Okay, acute adrenal thing. So could it be chronic adrenal? He's not gaining weight. Chronic adrenal. Chronic adrenal will come with vomiting. But chronic adrenal doesn't come only with loss of weight. It may come with vomiting, which is not common at this age, and the only type of long-term vomiting seen today is adrenoleukodystrophy, in which adreno part comes first and the CNS part follows even sometimes month or 2 months late. Whereas chronic tuberculous adrenal disease, all that is extremely rare today. And therefore, only thing that we may consider is adrenoleukodystrophy. And occasionally one could do straight away an MRI with only vomiting to rule out the problem. And could you tell me a simple investigation which will tell you whether it's a chronic adrenal even before doing an MRI? And that should be done first. Low sodium, high potassium. Low sodium, high potassium. Do any electrolyte. Okay, and you get this combination, sure, chronic adrenal and then leukodystrophy. So far we have no idea. But now let's discuss why he was not gaining weight, asymptomatic, not gaining weight, right? For 6 months. Yeah.
So, maybe sir, we'll take the loose motions
This
now.
is just now, right?
Yeah, so 10 days back he started vomiting.
Yeah. But
5
first,
days back
asymptomatic,
lose motion, lack of weight gain for 6 months.
that is only. So I thought we should know what the host is to begin with when he started this illness. Okay. In fact, what you could have done is you have done very well. You have told us the past history state. Your story could have been child has come with this. However, he was never well prior to this. And now what he was not well, 6 months he was not gaining weight. Then I said, oh, the first symptom is not gaining weight. So could we now look at what could be asymptomatic altering of weight?
What do you think?
And apparently from 9 months to 15 months. That's the age. He's just not gaining weight.
So commonest is poor weaning. Complementary feeding is poor.
Okay.
That
Then
is,
question would you have? Is history to pick up complementary feeds are not adequate?
So dietary habits.
And the first question is, has he been asking for feeds very often? Or has he anorexia? Again, anorexia would have been a systemic silent disease. And wanting more and more feed would have been simply a calorie deficit. Okay. But could it be a protein deficit? And their kwashakors don't want to feed. So what's your answer to that? Can protein deficiency present with wanting more fish? No. He has no interest in feeding.
what is seen in kwashiorkor or protein deficiency? Edema and
So he doesn't come with weight loss. Okay. Yeah. So this must be calorie only. Calorie means he wants to feed more. Okay. Now when he wants to feed more, okay, we don't know whether he wants milk more, he wants feed more, or he wants only fluid more, or he wants salt more. Any of thing of this component which he is not getting, he will be asking more and more. Now, when you are looking at adrenal, salt also may come in. And I recall adrenal disease, salt. The guy was asking for feed more and more, and they did not know why so much. He was passing a lot of urine, taking enough fluid. So if a child doesn't get enough fluids, he asks for more feed. He doesn't know asking for water. Salt is another, and of course, nutrition is third. So See, if you start thinking like that, you can imagine how you can learn medicine as an average pediatrician. This is good because we are all average and it's good for us. Okay. I think that's the thing. So we could have gone that thing, right? So let's now discuss this.
Okay, now just your thoughts on, sir.
Any vomiting which is going on for more than 2-3 days is not normal and less likely to be GI in the absence of any bilious vomiting. Now, regarding nutrition, this is a common story. He was gaining weight up to 6 months and because of but if he was not gaining weight, one point which occurred to my mind is his developmental milestones even after 6 months are normal. So if the child has failed to gain weight after 6 months, is walking, and those related to motor milestones should have lagged behind because he has been not doing well from 6 months to 14 months. This child shouldn't have walked, etc. Then we really don't know what is happening. If it was nutritional earlier, if it was metabolic, I don't know whether in metabolic there may be some compensation, whatever he wants he gets and whatever he doesn't want. But that I don't know. But that is one point we will keep in mind. Why has he not he faltered in weight, but he has not lost or he has not been delayed development. And neither gross motor nor social in all fields his development is normal. That was a bit of a surprise, which we'll keep in mind. Adrenal, sir, yes, always, and this is what we are likely to forget. Also, he became dehydrated. He was almost in shock, perhaps. He was kept, yeah, and
So,
quite significantly he became dehydrated.
so what are your thoughts on that fast breathing? On the 7th day of the illness, so if I understand right, 7 days of vomiting, last 2 days of loose motions, and 8th day or 7th day fast breathing. So what are your thoughts? Possibilities.
So the child has had a lot of volume loss, and following which he has gone into shock, and there is a compensatory metabolic breathing or an acidotic breathing that is happening.
Good. Now, whether the history of the volume of the losses is matching this story, you will have to answer. So that description of the loose motions, small quantity, yellowish, semi-solid, that's the loose motions. And vomiting, earlier we had a description, cup full, 4-5 times a day. So do you think this is good enough to push him in shock? On the face of it, it doesn't look like good enough. What else will you ask to corroborate this history? This is again the way you have to think. Perfect. Fast breathing, you're thinking of acidosis. Acidosis, commonest is hypovolemia. But is there enough reason to have hypovolemia? First question. So how will you confirm that this is hypovolemia? Excellent. So what is the urine output?
Urine output was maintained.
Urine output was maintained. So your hypovolemia is out. So now you are thinking that this is acidosis without hypovolemia. Then what are your thoughts?
Renal or a metabolic cause with it.
So renal or metabolic comes in. Okay. So this is the way you start thinking. Any other thought for a fast breathing in this scenario? Aspiration. Very good. So what question?
Any preceding event like vomiting or
Okay.
so if the fast breathing is gradually developing or any sudden event that have occurred, which is immediately after vomiting, after a large volume vomitus, the child started to have increased work of breathing.
So yeah.
Does the child gag or cough immediately after vomiting?
So again, let's get this fundas clear. Whenever any 1-year-old will aspirate, what will happen at the time of aspiration? There'll be history suggestive of choking and coughing. will he immediately become breathless? No, he will not become immediately breathless. So he'll choke, he'll start coughing, then his cough will start increasing, and then this chemical pneumonitis or plus minus infective pneumonitis will then make him tachypnic over the next some hours. Right? This will be your story of aspiration. But they have to cough, prominent cough. So that's question you will ask. So that is ruled out here. So somebody asked whether this could be diabetic ketoacidosis. So your thoughts on that?
Sir, a diabetic ketoacidosis presenting with vomiting, but no changes in consciousness for next couple of days. Just vomiting without abdominal pain, without any other metabolic derangements is little unusual.
So abdominal pain, of course, it's a small baby, we don't know. But what you are saying is right, that the progress of the disease doesn't look like a decay, right? So we've decided that unlikely hypovolemia and maybe metabolic, renal, all that we will keep in mind, and unlikely aspiration. Now, on a different note, suppose somebody goes in shock without enough losses to explain that. Then what are your thoughts in your mind? So you have a patient, he's not had too many losses, but he's gone in shock unexpectedly. What will come to your mind?
If he has gone in shock without losses, either intake or loss, then what is the cause? Cardiogenic is one. And if it's cardiogenic, what should be the history like? He may have had some history suggestive of a cardiac problem earlier, maybe in the form of cardiomyopathy, etc. Less likely to be VSD, ASD because they will not produce anything else. Yeah, he might be going to, but in which case he should have had relatively high fever. He should have been sick much earlier. And sickness for 1 or 2 days in the form of fever, irritability, or maybe even drowsiness. And then he goes in the septic shock phase. Anything else?
Any toxin ingestion?
Okay, any toxin ingestion gone on for a little longer time because poisoning will produce manifestations acutely, and after a few days either the whole story is over or he is deteriorating. So that good, it was toxin and drugs are often forgotten. We come to disease and systemic disease, and this is something which we tend to forget. Anything else?
So how does adrenal problems present in the newborn period? They go in shock, na, suddenly. So we're just learning that when you have a shock without commensurate losses, think whether this is one is sepsis, as sir said, and one whether it's a adrenal insufficiency which is pushing you into shock without commensurate losses. But of course, we'll have to look at whether he's really in shock or no. That, as we said, oliguria and all that,
Yeah.
we'll try and decide.
One part of history which we should always keep in mind, if we take that history, polyuria and dehydration don't go together. Norm. If they go together, then the and shock are both as a result of something else. For example, renal tubular acidosis are polydipsia and diabetes, as we say. So polyuria and shock are against each other. If there was polyuria, I would say even a good amount of urine in the child was that you can take as polyuria in the presence of. Then it was passing good amount of urine and he was still dehydrated. This doesn't go in favor of ordinary septic shock or other things. We will have to think of a renal tubular disorder or endocrine. Boy or a girl? One good thing is whenever you suspect something, just have a look at the genitals of a female. Sometimes there may clitoral hypertrophy. Use a diagnosis of CAH immediately. and they go in shock in no time. But of course, unless cared properly, they will not recover also because it can be very risky.
Fine. So these are all the aspects. You have given us a very big calorie deficit. So there is definitely primary malnutrition. Yeah, you were saying something. Okay, come.
So summarizing my case, my child, 1 year, 3 month old female child. So summarizing my case, my patient, 1 year, 3 month old female child with history of failure to thrive, along with episodes of sudden vomiting, followed by disproportionate tachycardia and dehydration, requiring fluid resuscitation in a birth and developmentally normal child with no other significant family history and a poor dietary history, without any apparent precipitating factors, to rule out first underlying congenital endocrinal abnormalities such as adrenal insufficiencies, acute on chronic. Second is acute decompensation of an inborn error of metabolism, which is organic acidemias. And third is an underlying renal disease, most likely a renal tubular disorder. Moving on to the examination, the child on presentation was afebrile, drowsy, with the heart rate 156 per minute, which was regular. Respiratory rate was 68 per minute, so as acidotic breathing was present. Saturation was 98%. Extremities were cold till ankles and wrists. Peripheral pulses were moderately felt and thready. Central pulses were well felt. CRT was around 5 seconds and BP was 64 by 38, which is less than fifth centile. Sugar levels were 52 milligrams per deciliter. Hello, am I audible? Pallavi ma'am, am I audible? So this child had presented in short tachypnea and acidotic breathing with cold peripheries, and the bedside blood sugar levels were 52 milligrams per deciliter.
Want your thoughts on 68 per minute and acidotic breathing. I just want your thoughts. Respiratory rate 68 per minute and acidotic breathing. What is acidotic breathing? Describe it.
An effortless tachypnea without any underlying respiratory pathology. It occurs as a compensation of an underlying metabolic acidosis so as to wash out more CO2.
Deep and fast.
Deep and fast.
Deep and rapid we typically describe as acidotic breathing. The point I'm making is that when it is deep, there is a limit to how rapid it can be. Because you need to go deep and then come out and go deep and come out. So I feel 68 is a little too much when there is acidotic breathing. there are two situations where there is a limit to the tachypnea. One is a inspiratory obstruction. When you have a inspiratory obstruction, you can't go beyond 45, 50. It is not easy. And similarly in deacidotic, because you need to reach that depth to come back. And 68 means in less than 1 second, you have to finish one breath. And uske andar deep also. So there is a bit of a limitation that.
Moving on to the head to examination, the head shape and size were within normal limits. There was no dysmorphic facies, no eye abnormalities except for sunken eyes. There were no skin changes, no limb abnormalities. Oral mucosa was dry, pallor was severe, and the child was in child had all the signs of severe dehydration, but no icterus, cyanosis, clubbing, lymphadenopathy, or edema. Moving on to the
So earlier you said the child was passing urine well. And now we are saying child is in severe dehydration. So now, as Kare sir pointed out, what are your thoughts then? If he's passing urine well in presence of severe dehydration.
renal abnormalities. Anthropometry, weight is 6.7 kilos, which is less than -3 standard deviation, severely underweight. Height is 70 centimeters, which is near to -3 standard deviation, just less than it. Suggestion of severe stunting. Mid upper arm circumference is less than 11.5 centimeters. Head circumference is between -2 to -1 standard deviation. Weight for height is -1 standard deviation to median. The child has acute on chronic malnutrition. Moving on to the systemic examination, the child was drowsy on arrival with GCS of 12/15. The pupils were bilaterally equally reacting to light. Tone was within normal limits. Power was more than 3/5. Reflexes were 2 plus, and the plantars were bilateral flexors. There was no obvious focal neurological deficits or no meningeal signs. Uh, a per abdo examination revealed a soft abdomen which was flat with umbilicus central with no dilated veins and scars. It was abdomen was soft on palpation, non-tender with no organomegaly. Was tympanic note heard all over the abdomen with bowel sounds present. Uh, in cardiovascular and respiratory system examinations were within normal limits. So my provisional impression for this child is a 1 year, 3 month old female child with acute on chronic malnutrition, presenting with severe episodes of vomiting followed by severe dehydration and shock with hypoglycemia, with acidotic breathing, which is disproportionate to the losses in a birth and developmentally normal child with a poor dietary history and no family history, without any history suggestive of any consumption, is most likely to be an unborn error of metabolism, such as organic acidemias, and acute adrenal insufficiency with an associated chronic underlying disorder, or an acute decompensated renal tubular disorder.
So what made you change the order of the provisional diagnosis after examination?
So there were no skin manifestations or head-to-toe manifestations of an chronic adrenal insufficiency in form of
Like,
skin hyperpigmentation, or so that's why the adrenals came a bit down. Similarly, for an underlying renal tubular disorder will have signs of rickets or will have signs of any calcium deficiency, or a delayed dentition maybe can be one of the presenting features of a renal tubular disorder, where height is much more affected as compared to the weight. Weight and height are almost equally affected in this child without any overt signs of any calcipenia. So uh, that then I've kept.
so incidentally, when weight and height are almost equally affected, what two things can it mean? Weight and height are equally affected means what? What is the interpretation?
An acute on chronic pathology. There was something chronic underlying going on to affect the height, and now an acute insult has also affected the weight.
Correct. So usually acute on chronic pathology will always have weight more affected than height. That's the usual story. Both are affected, but weight is affected more than weight. So if both are nearly same affected, what does it interpretation? So you have to look at compare clinically. So one interpretation is it is constitutional, means both are equally affected, means into bracket both are not affected. That is his genetic constitution. Okay. When the child is fine or the onset is very early. If the onset is very early, then over a period of time, after certain length of time, they will both be so badly affected that they look almost equally affected. That
I think looking backwards, now we know that it must have been an asymptomatic mother's impression that the baby was not gaining weight. But baby was not also gaining length. And at that time, if you would have checked weight and length, you would have said that no, weight and length are proportionate. So this is not really some disease failing to gain weight and thereafter also stop gaining length. So now we know that that part was possibly just a familial, constitutional, genetic, whatever. And now we separate that first story of 6 months of weight loss or not gaining weight from our discussion. And we will say the baby was healthy. We would have also confirmed by otherwise behavior, as he said, milestones were normal, he wanted to feed. So all that would have said. So the story possibly of 6 months of not gaining weight doesn't fit in once we got all those details. Or on examination, we got that. Thereafter, I feel that why should an organic acidemia vomit or any involuntary vomit because of metabolic, abnormal metabolite? For example, if it's an organic acidemia, you expect ammonia to be high, not as high as in a urea cycle defect, but certainly high. Second is you might expect hypoglycemia, at which time you may expect drowsiness, seizure. So I'm not sure whether, of course, there is a wide uh, presentation of all these disorders, but younger the disorder IM presents, more severe is the disorder. And I feel vomiting alone for a long time at that age, maybe where with wide spectrum of presentation, everything is possible. Here we know that that is more likely. But why is that child having that deep and rapid acidotic? That the organic acidemia has acidosis. They have hyperammonemia. They have hypoglycemia. So possibly a little wide spectrum of events coming up slowly. The deficiency is not so severe. That's first possibility looks like that. When you say acute adrenal insufficiency, that is not the point. That should not have featured here at all. And so also, what can decompensate renal tubular acidosis? I don't think renal tubular acidosis is decompensated by some external factor. It itself is worsening over time. So it's not a considered condition which can be suddenly exacerbated by, say, fever or some stress. Possibly not. So I feel out of these three, I stay with first because you have an acidosis, you have some disturbance, neurological, so ammonia, glucose, and you have a deep rapid respiration. So possibly the other two may not feature strongly in this child, right?
We don't know much about this organic, but most of them I thought were presenting very early in life. I mean, we consider diagnosis of inbornness of metabolism in first few weeks or first few months of life. If it has been going on for such a long time, uh, it should have manifested earlier. But as you said, sir, there are many abnormalities, and we don't know details of each abnormality. We think that something presenting suddenly in a newborn or a little older baby with no other cause to present with vomiting, dehydration, etc. is organic, but we don't know all of them so very well. When there is renal tubular problem, it's only not the sodium, potassium, but is almost associated disturbance of potassium and calcium. It's either associated with hyper of either calcium or if it is associated with hypocalcemia, you would add tetany. Hypercalcemia may not produce that. So only sodium loss is not common because if you take any of those RTA proximal distal, it is always associated abnormality of potassium and calcium.
Last time when Dr. Udani had come and we had discussed a probable, it was a 1 month fever and then a neurological disorder. And that time we said, is it related to some febrile illness, so autoimmune or infection induced, and then neurological. So we're trying to do that. When he saw MRI, he said it doesn't look like autoimmune encephalopathy of any kind. And thereafter, one of your students following 2 weeks later said that finally they are considering a urea cycle defect. So what I want to say is that that was a 4 or 5-year-old child and presenting with urea cycle defect. So when I read IEM, it all depends on how deficient you are in that particular enzyme. And occasionally the IEM can come in adult also for the first time. Though we are used to seeing them as soon as you start breastfeeding, in the first week they start with vomiting. That's classical, almost zero enzyme. But there is otherwise a wide description. If you take away the age of presentation, the story fits in with organoacidemia. Okay, because you have ammonia there, and that's why it's just vomiting. It's not causing an encephalopathy very early. Same thing, hypoglycemia, and then rapid acidosis. These are a high anion. So you might pick up the difference between sodium, potassium, and bicarb, and you will find high anion gap. And if that is so, then to me, it fits in an organic acid.
No genetic lab.
So nutritionally, I thought this baby was 3 kg at birth and 6.7 at 15 months. So I thought nutritionally baby is affected or is inadequate. So means you're discussing whether it could be constitutional. I think it's nutritionally affected. Maybe in the length they have some could be measurement errors, etc. I mean, what I mean is, suppose the same figures were 6.7 and 72 instead of 70, it would probably look like weight more affected than height types or something.
See, small weight loss must have occurred due to this illness also. But overall, if you see, and that's why that history at that time would have been very important, that he was otherwise normal. Okay, milestones were normal, he made a point. There is that severe malnutrition with even motor milestones are all right. Behavior, happy child, feeding well, all that would have made us little more. See, what we are discussing is out of clinical medicine that we are talking about, history taking is most difficult. And history taking takes the longest time. And if you don't, and as he always said, history is not his story. It has to be your story to get out of pain. And I think that's what we are. I think here we are ready, all here to learn with our mistakes, learn with our thinking process. But overall, that looks to me all right to me. That's the best possible diagnosis in my mind.
So I'll just brief about the course and what about this child. So this child then later was intubated within 1 hour in view of poor GCS along with the worsening shock. Uh, One. This child was later intubated and shifted to our PICU, where he required fluid and inotropic support. Our random blood sugar that was sent along with the initial investigations revealed the sugars of 39 milligrams per deciliter. The urine ketones were large, so a ketotic hypoglycemia, and the pH was 7.18. The bicarb was 3.6. It was on VBG on arrival, so along with a high anion gap metabolic acidosis. The electrolytes were normal of this child, with sodium being 137 and potassium being 4.2. Electrolytes throughout the stay in the hospital remained normal. And along with that, the USGs that were done did not reveal any nephrocalcinosis. The urinary pH was also within normal limits, along with normal urinary specific gravity. We had, after the stabilization, initially we had sent his metabolic workup along with lactate and ammonia. The lactates were initially high. Even the VBG lactates were 4.5, which was sent on arrival. Post stabilization, the child got extubated on third day of admission. Post stabilization, we had repeated all her workup. So that workup revealed a normal ammonia with plasma ammonia of 53, a lactate which was around 25. For reference values are 12 to 28. Our lab values were 27, with repeat urinary ketones which was trace. And since then, only after the first episode that on the presentation, the child was hypoglycemic. Since then, the child was euglycemic without requiring any glucose infusion rate. So this was a child who presented with severe high anion gap metabolic acidosis, with a ketotic hypoglycemia, with normal electrolytes, with a normal plasma ammonia. So we had sent her urinary GCMS and TMS, and also the whole exome sequencing of this child. The urinary GCMS TMS has given us three different possibilities. One is organic acidemia. Second is ketolysis defect. But the thing that goes against ketolysis defect is the ketones which are positive in the urine. So ketotic hypoglycemia. Third differential that was given was a mitochondrial disorder. But there is no other organ involvement or no lactic acidosis. And the fourth differential that was given was a fructose 1,6 bisphosphatase deficiency. So this was a gluconeogenesis enzyme defect, where the children usually have a neonatal age group of presentation on an earlier age group of representation. There is a defect in the glycogen breakdown. So because of the fructose 1,6 bisphosphatase defect, there is defective gluconeogenesis. So patients usually present with hypoglycemia, seizures, and developmental delay, along with hepatomegaly. So this child did not have any organomegaly. The age of presentation was at around 15 months, and there was no history of seizures or developmental delay. So because the urinary GCMS and TMS were also not very conclusive, we have sent a whole exome sequencing for this child, and which is awaited. The child is vitally stable. After the workup, the child has gotten discharged, and we have started her on. We had nutritionist, so we had started her on mitochondrial cocktail for now, along with the dietary supplements, and she's on regular follow-up with our OPD.
So one question, you said pH 7.18 and lactic acidosis and high anion gap. What would happen if this child was in shock purely out of hypovolemia? Would any of these change?
No, sir. No, sir.
So that's the point I'm trying to make. So on that day, the picture could well be simply hypovolemic shock. It will give you high anion gap acidosis. It will give you high lactates. It will do the same picture. Where is the catch? After restoring volume and perfusion, if your lactate still remains high, then you know that this is not just due to tissue ischemia. So now you are on a metabolic disorder, right? But to begin with, it could well have been just hypoperfusion.
Diarrhea fit into all this. There was loose motion for 4-5 days. If we would have been in that initial phase, what sense we would make of that diarrhea at that time?
I personally thought if the description is right, that diarrhea was very non-specific. Just 3-4 motions, semi-solid. So it was not really diarrhea and it didn't contribute to the illness.
I think when diarrhea comes a little later in the course of illness and it's self-limiting, it often means only that for some reason the intestines are in a hurry. Now that could be even vomiting, starvation, intestinal peristalsis. So when stools are small in number and also small in quantity, it's usually not a primary intestinal disorder, or that's why we will not take into discussion. But you are right that how do you explain diarrhea? So we explain by saying that it could be a result of possibly a starvation, intestinal hurry, whatever it is.
hypermobility in general of GI system in the form of vomiting, loose motions.
Anytime acute stress of any kind, be it an acute illness, has also a few vomits, few loose stools, but thereafter nothing. So that could be autonomic nervous system stimulation for a while.
I think is correct. One lesson to be learned is when when weight and length seem to be lost and the development, physical and gross motor is maintained, then we should not consider nutritional cause as primary, and we should alternatively think of metabolic. Because otherwise, if it is nutritional, it has to be a parallel affection of gross motor, at least if not mind. So we'll take that into consideration.
I remember when I was at Wadia, our endocrine department asked me to see a child because the parents said length is small. Okay. And believe me, the weight was also small. So now, yeah. And therefore, the length is small and an infant, maybe 8, 10 months old, so naturally endocrinal problem. Okay, nothing rickets. And then said, no, we are not getting anything. But the weight was also small, something of this kind. So sometimes we get focused on weight only or length only, and then we miss out something. So
Little less relevant in a small baby, must have a look at the parents' length also. And now that we see length of every child, if I see a child, 1-year-old child at about 69, 70, almost always the parents are short. What I'm trying to say is it gets affected as early as that and not only in older child or adolescents.
Good evening, everyone. Good evening, everyone. I'm Dr. Mayuri. I'm presenting short case. 11 years old girl, second by birth order, born of non-consensuous marriages, resident of Bandra, hailing from Aurangabad, Maharashtra, Muslim by religion, Sheikh by community, brought by parents with complaint of fever since 1 month, generalized weakness since 1 month, bluish purple spots all over the body since 2 days, gum bleeding since 1 day, dark sticky stool since 1 day, and vomiting since 1 day.
the reason is that last 2, 3 days, many things are happening which becomes easy. Okay. But let's discuss fever and generalized weakness for 1 month. And don't take into consideration the remaining thing. Because the question to learn is, could we have anticipated such a thing to happen? Okay, that is important. So we will discuss just 1 month of weakness and fever and nothing else.
Fever can be due to
Nee, so combine the two. Don't take fever alone. So you have fever for 1 month and generalized weakness for 1 month. So if you combine these two, what are all the thoughts that come to your mind? Think properly. Infective.
The weakness, probably muscles are not getting enough energy.
Very good. Muscles are not getting energy. So now what all kind of energy do muscles need? And who brings it? All that. So take it one by one. What all do muscles need?
The blood supply, it brings
Very good.
oxygen, it brings glucose. Oxygen and glucose basically required. The lungs, so probably lungs are affected. Hemoglobin, heart.
Plus you said sugar.
Yes, sir.
So now ask more questions to find out where is the anatomy. Could it be lung not creating oxygen? Could be the heart not pushing it? Could be low hemoglobin. And therefore lung would have been tachypnic, heart would have been tachycardic or palpitation, 11-year-old. Okay. Low glucose, what the cause? Diabetes, not for a long time, or but you would have had polyuria, polyphagia. Okay. If none of these things are in the history negative, then you ask the mother, you find the child is staying. And then you get to hematology straight off from there. Now hematology with fever. I thought hematology is without fever.
Leukemias.
Right? Right? That's the way. Many other thoughts should come to you.
ITP, why jump to leukemia? ITP. Yes, but everything.
Fight with sir. He's saying ITP. Fight. So what is the problem here? What is the and then the other ways in which you would, so you said infection. So I mean, I'm just saying how we think. So fever and generalized weakness, broadly, yeah, it could be tuberculosis. But then where is the catch? What should be there, what is not there? There should be some other symptoms of localization, right? So in other words, we've discussed this, that if a patient is saying fever since 1 month and weakness is the only other complaint, the fever is not localizing to any organ. And therefore, bacterial infection, viral infection, tuberculosis, all those are out. So you are thinking of a non-infective cause of fever, right?
Child was apparently all right 1 month back when she developed fever, which was moderate to high grade, intermittent, relieved on taking medications. Child was active in interfebrile period. Fever was associated with headache and generalized weakness and not associated with chills, rash, and rigor. Bluish purple spots all over the body since 1 day, sudden in onset, gradually progressive, started on trunk and spread to all over the body, including face and conjunctiva, and that was not associated with any trauma. Then child was having gum bleeding and dark, sticky, false-smelling stool since 1 day, and vomiting since 1 day, which was non-bilious, non-projectile, and containing food particle. For the above complaint, child was admitted in the outside hospital for the 3 days. Then there some blood investigations were done, told to have low platelet, 4 bag of platelet transfused, and some expensive medications were given. Even after a platelet transfusion, there was worsening in the bleeding. And over the period of 3 days, child sensorium worsened and shifted to the Sion Hospital for further management.
I wanted to interrupt for one thing before I forget. Sentence which is said, write it on our mind. If there has been fever for 1 month with generalized weakness, infection in cause, it must localize. It has not localized to any system, including tuberculosis, some respiratory, some CNS. Then it is non-infective cause of fever. You must write.
No history of cough, cold, no history of ear discharge, no history of burning during micturition, no history of any bony pain, no history of abdominal mass, and no history of visual disturbances or blurring of vision, no history of convulsion, no history of recurrent infection or past admissions, no history of recent vaccination, no history of similar complaints in the family member. There was a history of tuberculosis in mother 15 years back, for which she has taken AKT for 6 months. And also there is a history of tuberculosis in maternal aunt and uncle 2 years back, for which they have taken AKT for 6 months. And in child, there was a history of 2 kg weight loss in a month. In past history, there is no history of admissions in the past. ANC history was registered, supplements were taken, TT injection taken, USG scans were done, told to be normal. And birth history, full-term normal vaginal delivery. Birth weight was 2.5 kg. Baby cried immediately after birth. No history of NICU stay. No history of neonatal jaundice and discharged on day of life 4.
Before, before we got anemia and the rest of it, could it not have been TB? Not in this child, but fever and general weakness. Could it be TB? Forget the rest, what happened.
The life somewhere.
So, primary complex, a small lesion, small hilar lymph node, all that you have is just weakness, fever.
It can.
Because there is a strong family history of TB. So your comment on my statement, strong family history of TB, mother, aunt, everyone. And discharge fever for 1 month, weakness. Absolute TB only. No, that I'm asking, if this child did not have that, then you would have called it TB? And I want you to say, no, we would not have called TB. Why?
So, so forget the fever, take the weakness. So weakness, as she said, to begin with is muscle, and then we said all those causes. But now look at it in a different way. When does a disease cause weakness? What is the timeline of a disease causing weakness? So getting my question? So tuberculosis of one day will cause weakness. When will it cause weakness?
Two things. One is the virulence of the pathogen. If it is acute and strong enough, it will overcome and can cause weakness, or the capability of the host or the host factors. So if the gradually over a period of time, if the infection persists, it starts overcoming the host factors, and then the generalized weakness might set in. Either the virulence or the chronicity of the disease.
Other thoughts? So what I am trying to say is that when weakness comes from the patient as a chief complaint, it is not secondary to any such cause like tuberculosis, etc., because that will come at the much later stage of a disease. So 100 things will happen. He will not eat, he will lose a lot of weight, he will become weak. Then that weakness will come. So weakness is never a chief complaint in all those diseases. It is one of the side complaints type.
See, by weakness we mean we don't have a reserve that is required for muscles or every system in the body to work. Which means the mitochondria who store energy, that energy is not getting replenished, used. Why is that happening there? So the intake and output imbalance. When you cannot have food for a month or not adequate food for a month, but you have to work more than normal. Imagine less of intake and more of work. Why more of work in TB? And increased basal metabolic rate. There is an illness there. There is a fight going on there. There is a destruction there. So there is an increased metabolic rate on one extreme and a lack of intake on the other. The only point is that, therefore, how much has he lost may have a word. But I still want you to tell me that in this story, without that bleeding, why not TB? And I wanted you to ask now, I'll ask the same question another way. What is family history of TB? My grandfather had TB. Family history? Why? My grandfather was in my family. How can you say no? So what is family history of TB?
He said close contact.
My grandfather, of course, very close contact. How can you say no?
So by definition, what is to be taken as family history of TB? Sputum positive is
Was pulmonary or extrapulmonary, we need to ask if and whether it was microbiologically proven, and also how long back it was, whether the child was exposed or not to the.
6 months to 1 year. I don't remember the exact duration, but it's not 2 years, less than a year. When the uncle and aunt were 2 years back.
1 year. Treated or otherwise. Okay. And why 1 year? Why not 3 months? Why not 2 years? And the reason is, if last 1 year somebody in the family has that TB, well diagnosed, well treated, whatever, when you treat TB, you never get rid of the last mycobacterium in your body. And therefore, you're not cured in that sense. You hope to be cured because of your own immune system taking charge of those small number of bacteria and keeping them under control, but they may be still living. And that's why they may reactivate even later in life, adolescence, pregnancy, etc. So if 1 year has passed in the family and everybody is fine, you almost take it that now that person would not have transmitted infection to others. That is the reason. Now, I wanted you to pick that up. In an exam, this is a very common question asked and a very common mistake, unfortunately. Okay. And look at that story. Somebody in the past maternal aunt, etc. Therefore, that story has no meaning, right?
the sputum positivity and all that is not to be considered while considering a contact, because whichever form of tuberculosis the index case the patient may have, you can't be 100% sure that there were no bacilli in the pulmonary system and the person was not excreting bacilli. You didn't prove it doesn't mean there were no bacilli. So to that extent, and most other forms of tuberculosis are secondary to pulmonary, right? So therefore, that is not to be taken as a criteria. As in, if somebody was sputum negative, you can't say no history of contact.
Where is the focus of TB in cervical lymphadenitis? Lung. He said mostly it's pulmonary. That's what she said, extrapulmonary. But mostly pulmonary becomes extrapulmonary. But what about cervical lymph node? It comes up from lung up there. Then where is the primary focus in a cervical TB? It may be upper respiratory, even in tonsil. And that primary focus is not seen. So just to clarify that, okay, primary complex mostly yes, lung, And therefore, that's what I wanted you to know this well, that definition of family history is any member, yes, closely connected in the last 1 year has had TB, treated, untreated, whatever.
If the glands involved are posterior cervical and anterior cervical, then pharynx also is not to be forgotten because the tonsil drainage is in the jugulodigastric. Jugulodigastric, and these are involved in tonsils and pharynx. But pharyngitis does not give rise to big jugulodigastric, but other glands. And coming to the word uh, loss of energy, weakness, catabolism is more than anabolism. One simple, whatever cause of catabolism, what is being destroyed is not being replaced.
And that is how, if lymph node is posterior, it's very unlikely TB. If it's anterior to sternomastoid, it's likely to be TB. And if it's posterior, then you must first look at the scalp. And you will have a draining area then. So keep that in mind.
Developmental history, school-going children studies in fifth standard, good scholastic performance. Immunized till 5 years of age. Dietary history, eat from the family pot, mixed diet. Calorie deficit is 300 kilocalories and protein deficit is 3 grams per day. On examination, child was drowsy. Heart rate was 72 beats per minute. RR was 40 per minute. Saturation was 94% on room air. BP was 120 by 60 mmHg, which is between the 90 to 95th centile. And then GCS is E4, V4, M5. Peripheral pulses well felt, central pulses well felt, extremities warm and pallor present. On systemic examination, in CNS, child was drowsy, pupil were bilaterally reactive to light, tone power reflexes normal, and no signs of meningeal irritation, but there was sign of raised ICT present. Then on CVS, S1, S2 were normal. On RS, ear entry bilaterally equal and clear, perrupto soft and non-tender.
What signs of raised ICT?
Sir, bradycardia, then hypertension, and there was tachypnea, irregular breathing.
These are only signs of raised ICT. The saturation was 94 on the lower side. No lung pathology.
Child was tachypnic, and she was not maintaining saturation.
Despite of being tachypneic.
Not followed. He asked you raised ICT sign. Is tachypnea sign?
She's saying that triad of bradycardia, hypertension, and irregular breathing. That is why raised ICT.
I think that hypertension bradycardia is a dying child in an ICU. And if this child is that sick, it may be possible. But better signs are not those signs. Better signs are papilledema, that is number one. Maybe pyramidal signs, if there is some occupation. And if it's a child, if whatever age, massive sign. Okay. But do you think this 11-year-old will have open sutures? When do the sutures close?
1.5 year, the fontanelle, both fontanelles also closed.
Shows that close at 18 years of age. And what you're trying to say is that they approximate at 1 year, 1.5 years, but the permanent comes at adolescent, and therefore massive ones in pediatric age group at any age, right? Those would have been better sign. Sometimes you can have a false localizing sign of a raised ICT. So keep that in mind. Bradycardia hypertension is a late sign, and I don't think any one of us has seen that. And you should not wait for it unless you go with the death certificate in your hand. So that is not a good sign to go by. I wanted you to comment on the blood pressure that you talked about. Can you put that slide 2 slides back? Yeah. Yeah, next one. No. Yeah. You said 120 by 60, 90, 95th centile. You think 60 is also 90, 95th centile?
Sir, for her age, according that BP centiles, it was falling between 90 to 95th centile. No, it was systolic actually.
You
Most
call it
probably.
90, 95th. Diastolic is low.
Yes.
Only the systolic is on the higher side. Diastolic is not on the higher side. Diastolic is in fact low, right? So that 90-95th may apply to only that 120. Understood? And normally, when do you get such a wide pulse pressure?
White pulse pressure is generally will get in warm shock, but systolic pressure up to 120 in warm shock is highly unlikely.
Correct. And why do you get hypertension in raised ICP? I mean, high BP or whatever. BP on the higher centiles. Why do you get in raised ICP?
Perfusion pressure. It's just to equalize cerebral perfusion pressure, so that the brain will be perfused adequately despite raised ICT.
Would the diastolic go low in that situation? So what I'm saying is perfusion pressure is also dependent on mean arterial pressure, and mean arterial pressure will not be good if your diastolic is low. So what I'm trying to say is that if the body were to compensate for raised ICP by getting the BP on the 95th centile, it would not be this wide pulse pressure. That's the point I'm trying to make, right?
To me, this is not of much concern, but all that you know is 60 millimeters is the pulse pressure. And normally you call it, when it's 50% of the systolic, you call it a wide pulse pressure. So this is a wide pulse pressure.
Heart rate of 72 and respiratory rate is 40. So much up for a 10-year-old child, 40 is tachypnea with almost dyspnea. And the heart rate, the only reason the heart rate could be low is respiratory. Bradycardia. Otherwise, any time the respiratory rate goes to 40, then it has to go, the heart rate has to go much higher. And one small point, you saw the blood pressure and you said that for that particular age, this is it. I think blood pressure correlates more with the length than the age. Because the norms are given are according to the length rather than the age.
Then 11 years old girl, second by birth order, born of non-consensuous marriages, came with complaint of fever since 1 month, generalized weakness since 1 month, bluish purple spots over the body since 2 days, gum bleeding and history of dark sticky stool since 1 day, with history of tuberculosis in mother and maternal aunt and uncle, with normal birth and ANC history, developmentally appropriate for age, immunized till 5 years of age, with signs of raised ICTs, most likely case of acute viral illness, functional platelet disorder, and it can be acute leukemia also.
So I want your discussion on acute viral illness and functional platelet disorder. Your thoughts.
In acute viral illness with signs of raised ICT, we have to look for sensorium. If the sensorium is not that good, we can say it's a viral encephalomyelitis. And for the platelet history of no, it might not be acute viral illness. 1 minute.
platelet functional disorder. What all does it not explain?
Fever, fever won't be there, and generalized weakness also won't be there.
So these two differentials do not fit in that 1 month history, right? So we wouldn't give this differential here.
But sir, it can be secondary to some infectious origin also. And fever was that due to infection.
Agreed. But which infection fever goes on for 1 month and after 1 month causes these bluish purple spots?
Fever was since 1 month on and off duration.
Agreed, on and off that, but it's a continuous illness, no? It is not separate illnesses. You get my point? So, if this same story would have been a shorter story, you would have said, argued for infectious mononucleosis or some such disorders. But there also, you don't get so many purple spots, right? So, this so much petechia and bleeding and all that is strongly against any acute, any viral illness. And this story though is too long, right? And same way functional platelet disorder. So functional platelet disorder, you will give a differential. First of all, clinically, it is very difficult to say it is functional and not quantitative thrombocytopenia. Clinically, you will talk of quantitative only first. Qualitative is something which you get on investigation, right?
Functional platelet disorder does not, to my mind, cause bleeding everywhere else. It just causes ecchymotic spasms. Patient is asymptomatic otherwise. He has no complaint. And in fact, it becomes the differential diagnosis of a fixed drug reaction, which also looks similar, which also stays for about few weeks or months. And therefore, functional platelet disorder doesn't come with extensive bleeding all over. This child has that. And therefore, the question is, what is this neurological symptoms in this child? Logically, you would say there is some bleed there. Okay, thrombocytopenic bleed occurs in anywhere, or a leukemic would. Story of 1 month puts us to say leukemia. Now that story, we need to be very sure, but even the immune-mediated thrombocytopenic period, purpura doesn't come after a month or so. It's a short story. And often there is no fever at all when it presents. Fever has disappeared. It has triggered all that. So I think it is not congruent with what history we had. And in fact, with history, I thought you were going to present an acute myeloid leukemia with gums bleeding and so on. So let's see what happened. Doesn't matter. We are like what we are learning each time is history is so difficult. And what we start uh, history given by the mother, reliable. Okay. I know. Bala from Chennai always say, mother is always reliable. Don't tell me that history is reliable. He's always said that. And therefore, I think history taking is a skill. And you have to learn that skill to begin with. Anyway, it doesn't matter. We will see what the investigations.
Sir, CT brain was suggestive of multiple intraparenchymal hemorrhage noted in the left frontoparietal region and right occipital region with surrounding hypodensity suggestive of vasogenic edema. Then mass effect is noted in the form of midline shift of 1.8 mm at the level of the third ventricle. In investigations, CBC trend, there is a decreased trend of platelet, and on 5th of June, the platelet count was 20,000 after transfusion of platelet. Even after that, platelet trend decreased. And on 12th of June, HB was 9.8, hematocrit was 28.3, counts were 12.06, and platelet was 2K only. Then total bili was 1.7 and direct bili was 0.8. OT was 27 and PT 24. ALP is 157. Total protein is 10.4 and albumin is 4. RFT was no 5 and 0.8.
Total protein 10.4.
Yes, sir. Then USG A plus P suggestive of mild hepatomegaly and mild splenomegaly. USG next suggestive of multiple cervical lymph node, and urinarium was within normal limit. Stoolarium, occult blood present, and 6 to 7 RBCs were present. Fundus, no evidence of papilloedema and no evidence of retinal hemorrhage. Then ANA blot was sent, RO 52 positive and AMA M2 positive. PTINR was 16.8 and 1.055 and DCT was positive. This was the X-ray.
So what do you think? You can read the X-ray?
Yes, sir. This is the AP well centralized X-ray showing the there was hilar shadow presented in the right region around the sternum.
Okay, so hilar prominence on the right side. What about the left side? Left side also there is a prominent shadow, no? So what could these shadows be?
Medias. No,
Mediastinal masses.
massive. It can be mediastinal.
Can be lymph nodes.
Yeah.
Yeah. Okay.
Then after that X-ray, CT chest was done, suggestive of multiple discrete and confluent centrilobular nodules forming areas of consolidation is noted involving posterior segment of right upper lobe and right lower lobe, sparing anterobasal segment, and left parenchyma, sparing apicoposterior and anterobasal segment. Fibrocavitary changes noted in posterobasal segment of right lower lobe. There was a mediastinal lymphadenopathy, and these features suggestive of active infective etiology. And visualized abdominal section reveals multiple enlarged lymph nodes, periportal, peripancreatic, and gastrosplenic region. So, 11 years old girl, second by birth order, born of non-consensuous marriage, with complaint of fever and generalized weakness since 1 month, bluish purple spots over body, gum bleeding and dark sticky stool since 1 to 2 days, with history of COX contact, which CT chest suggestive of active infective etiology, and CT brain suggestive of multiple intraparenchymal bleed, CBC suggestive of decreasing trend of platelet, and even after platelet transfusion, worsening even after platelet transfusion, and improved after giving steroids. Is case of immune thrombocytopenia secondary to infectious etiology, tuberculosis. For that patient course in what? Firstly, though we have transfused platelet and IVIG given. So even after platelet transfusion, the bleeding doesn't stop, it worsened. Then after we have given MPS, pulse regime, and predni continued. Then after that chest X-ray, we have done CT chest. On that tuberculosis was detected and AKT have been started. Then child improved, and on discharge the platelet count was 90,000.
Have you got a AFB anywhere? Like you got any biopsy done? You've done GL for AFB?
No microbiological evidence.
No microbiology.
CT.
And you've done a lymph node biopsy anywhere? Externally also there were lymph nodes?
No, sir. Lymph node biopsy were not done. On that CT report, we have started AKT for that children.
How do we know this is not a suppression of leukemia by steroids and AKT just happened to be there unless we have a microbiological proof?
But there was a fibrocavitary changes on the CT scan and strong family history.
No, that is fine. See, the points that are very surprising are, first of all, that thing about platelet not coming up even after platelet transfusion. suggests a autoimmune thrombocytopenia. Then you said DCT positive. It suggests autoimmune hemolytic anemia. Then you said protein is 10.8 with albumin of 4. So if all that is correct, then the rest is all globulin. So much of high globulin with the autoimmune hemolytic, autoimmune thrombocytopenia. So it suggests some autoimmune condition. And then with so much of lymphadenopathy, it is likely to be still a hematological malignancy type of a thing. So means there may be multiple diagnoses, but it is all the more important here that we have to try and prove the tuberculosis microbiologically and get one biopsy from somewhere to look at the tissue. You had such big lymph nodes also here. So we should get some biopsy and get a tissue diagnosis.
Bronchoalveolar lavage,
Yeah, we have tried.
negative.
No, sir. On bronchoalveolar lavage, MTB was not detected.
In a short time of 1 month in an apparently healthy child, this TB has spread all over. That's a little worrying feature. Okay. The post should have restricted its spread. Okay. That fibrotic lung lesion doesn't mean TB. That's something old has happened. Why should we take that? Fibrotic lung means it must have happened last year or 5 years ago. Why is that lymph node today? So I'm not going to buy a fibrotic lung. And that also fibrotic is an imagination of a radiologist. We haven't said it's fibrosis. And therefore, what looks like a localized lesion but not active, they called it fibrotic. That's not a cause of pain. With so many lymph nodes, why are we not picking up histopathology and also the bacteriology? That's number one. Second is, at least I have not read, nor seen, nor heard acute immune-mediated thrombocytopenic purpura following TB. Well, it can occur, I'm sure. But what immune responses to TB we have seen are localized. TBM is immune-mediated. Pleural effusion is immune-mediated. But this is a systemic hematological, okay, something that, of course, literature might have occasional things, something like that. But difficult. But first thing, I think, how can today we start AKT without histopathology, bacteriology? Okay, because of fibrotic. Fibrotic is old, healed lesion. And today is an active lesion. So I suppose the minimum you should do is to search for a bacteriological diagnosis. Then the question is, yes, you have a TB. If you have proved, then we need to look at the literature to say how often one has seen all such hematological manifestation, okay, and how common are multiple lymph nodes coming up all over within a short period. I think we need to revise that. But first, forget what it turns out to be. How can, in today's era, TB diagnosed without histopathology and bacteriology? The whole infectious disease, people are barking at us. Okay. So I think that's the minimum. You should do it and let us know what it is, right?
HIV is negative.
Yes, sir. HIV. also.
HIV was done and it is negative.
Yeah.
And what about the differential count? Like WBCs, the differentials were all normal all along.
Um,
Breakup of WBC count, you showed us some WBC counts.
WBC was 5,600 and in that range only.
Okay.
Poly.
And after this 6.6 hemoglobin, you've given a blood transfusion, Paxil also.
No, sir. For that child in our ward, we have transfused platelet and the IVIG given. Blood transfusion. we have-
You've not given Paxil.
No. Sir, this was the report in the outside hospital. And in that outside hospital, child has transfused PRC transfusion. But in our hospital, we have
What
transferred.
date he came to you? All this 3rd to 12th, he was here or
No,
outside?
sir, outside hospital, and sorry, on in that hospital there was one PRC transfusion on the HB of 6.6, and after post transfusion HB was 9.7. And when he comes to our hospital, we have transfused him 4 bags of platelet and IVIG transfusion.
When you see the thrombocytopenic purpura that needs a platelet transfusion, immune mediated generally doesn't need it, and it's also not effective. But if you have a doubt, what's the reason for thrombocytopenia, and you have to give a platelet because platelets are terribly down, there is a risk, etc. Then the best way to do is to give a platelet transfusion, and at the end of 4 hours and at the end of 24 hours, you do a platelet count. If at the end of 4 hours your platelet is still low, it's a destruction. And if it's not low at that time, it has come up, but at the end of 24 hours it has gone down, then it's a problem of production. And one way to differentiate whether your platelets are low because of destruction or a production is to do two platelet counts, 4 hours and 24 hours. 4 hours is destruction, 24 hours is not able to produce. In which case you might do a bone marrow. Okay. Because we are not happy about the whole situation. One of TB, one of also bleeding. And therefore, we might consider even a bone marrow, but before that, confirm TB and then look at this. Why should platelet? In fact, if it's an autoimmune, platelet transfusions are not recommended and is bound to fail. Okay, but it could be problem of destruction. Now, if you see the hemoglobins, they are pretty low at times, 7.6, 6.6. And look at the WBC, also on the lower side. You seem to be having all three cell lines involved. Okay. So few things are a bit suspicious. And I think the issue is that when you discuss investigations without much strong basis of a clinical impression, then you get more confused. So we are not sure what we are talking about, but we are only confused. Yes, and we are confused in this sense. But again, a complaint that we have voiced several times, we do not know what happens finally to such patients. When we come back again, we must know where we did wrong. Okay, otherwise we will never learn. All that we learn is, yes, we even now are confused. That I know very well.
How many days now this child is on ATT?
Sir, we have started AKT some 15 days to 1 month back only.
Which steroid?
Firstly, MPS was given and then prednisone, oral steroid tablet.
After these reports this child gave
Yeah.
to you, it's only 25th of June today. These reports are hardly 13 days old.
No, 6 June, and yeah, this child was currently admitted, but अभी discharged है वो, and 15 days 1 month का history है उसका.
नहीं, AKT को already 15 days.
Yeah, we have started AKT.
Yeah. Last time that rickets का क्या हुआ? Any? There was that major severe rickets, na? 5 big boy with lower limb.
Yet to follow up in nephropathy. We will update.
You all had done some levels, na? 125, वो सब levels आया कि नहीं आया? We were discussing resistant rickets and all. ठीक. Okay, fine. So we'll stop here. Thank you. There are questions. Online, anybody wants to speak anything or comment anything or ask anything?
If child is responding to AKT, should we go for biopsy at this stage?
So that's why we are asking you so many details. See, as we said, if this date timeline is correct, your AKT is about 13 days now. From 12th August, if the child came to you on 12th June, so about 12, 13 days of AKT. So what is the definition of your response? What do you mean by response? Simultaneously, we have given steroids. So we don't know how much of the benefit, whatever, benefit in terms of absence of fever, better appetite, less tired, how much of it is due to PRC transfusion, how much of it is due to steroid, we don't know. So it would be very much worth it to get a biopsy now. Send that biopsy only for everything, for gene expert, for everything, and plus it will give us a histopath diagnosis, right? So it should be worth it. Thank you. Good. Good presentation. Pallavi ma'am, anybody else has any online questions or anybody? Fine. So we'll stop here and we'll meet next Thursday. Okay. Thank you. Thank you, everyone.